This is a case of a 75-year-old male with weakness. The presentation was that he had a syncopal episode prior to your arrival. He's alert and he's oriented and he's cold to the touch with clammy skin. So the providers decided to do a 12-lead EKG, but I just want you to think in your approach and the assessment how they got there. Obviously, we're checking with our primary survey, airway, breathing, circulation, all of these things. And going to the EKG, the 12-lead is part of our secondary survey because we have a cardiovascular issue within our differential, right? So I'm sure that they first put him on the 4-lead and they saw what you see here in lead 2, the wide complex tachycardia, right? And then they decided to do a 12-lead EKG. So I want you to go ahead and take a look at this 12-lead. Now, on an EMS call, depending on your patient's stability, you have to make these decisions sometimes rather quickly. And with the anxiety of being a provider on that call, you might be able to interpret the 12-lead better now than if you were in the clinical setting. There's a saying that I have a 100% success rate of reading EKGs when I'm not providing treatment for that patient. That kind of holds true even for me in running calls. If the patient was my patient, putting the 12-lead, it would take me a lot longer to interpret that EKG because there's a lot more responsibility that goes along with making that decision. So if you look at this systematically, we're looking at the rate and the rhythm first, right? So the rate's obviously fast. If you know the 300 method, the box method, if you have a QRS on this bold line, hopefully, and then another one on this line, the rate would be 300 because 300 divided by one big box is 300. If the next QRS were to fall on the second fold line, then the rate would be 150 because 300 divided by 2 is, of course, 150. So we're in between that. And then I'd say this is around the 200 mark, right, for the rate. And of course, the monitor helps you with that. The diagnostics on the 12-lead that prints out helps you with that as well. So we have a tachycardia, and it is regular. If you were to space out these QRSs, they are very consistent. You have a regular R to R interval. If it was irregular, that would change our differential. But we have a regular tachycardia. Going systematically, you would check your axis next, and this is a rightward axis. You have an S wave and lead 1, positive, 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 and 2, 3 AVF. So this would be considered a rightward axis, and AVR is, of course, negative. Then you would go down and you would look at your intervals, your morphology, and that's when you identify that you have a wide QRS complex with what looks in V1 to be a right bundle branch block morphology. All right. So let's just call this a wide complex tachycardia with a right bundle branch block morphology in V1. We can all agree on that. Our differential for that should include, of course, ventricular tachycardia. Of course, it could be sinus tach with aberrancy, although at this rate, it would be highly unlikely. But SVT with aberrancy is possible. A flutter with aberrancy is possible. And then you always need to consider some potential electrolyte derangement like hyperkalemia or toxicity, like a TCA overdose can cause something that looks like this. So we have all of that in mind. Due to our intervals, you can't really distinguish the ST segment when the rate's this fast. In this case, the dysrhythmia is the issue. When you start getting to rates near 200, it is absolutely a re-entry tachycardia that needs to be managed. All right, so let's move on. So again, our differential should be VTAC, SVT with aberrancy, A flutter with aberrancy, electrolyte derangement, or toxicity. The patient has a blood pressure of 110/60, a respiratory rate around 26, and a 97% saturation. He has a history of angina, pacemaker without a defibrillator. That's important, right? Because he's not being shocked, and hypertension. You would be concerned about with this patient. What I'm also concerned about, this history doesn't match my vitals. Hypertension with a blood pressure of 110/60. And then this patient's presentation, their presentation was that they were cold and clammy. They had a syncopal episode. So they are hypoperfused, right? This blood pressure, while it looks beautiful on paper, is probably pretty low for this patient. And it makes sense that it would be low. Looking at our differential, we don't have any concerns about toxicity. There's no history of this patient taking tricyclic antidepressants. That's the big one. That can cause a lot of EKG changes. Anything that can alter your pH can cause EKG changes. And then electrolyte derangement, that's much more concerning when you get a very wide QRS complex, when the patient is altered, when there is a history of renal failure or CHF. I say or CHF because it can cause renal failure acutely and unknown. All of these things come into play when you're interpreting a 12 lead. That's why we always say that every 12 lead comes with a patient. So consider the presentation and that patient's history. So looking back at the 12 lead, with that in mind, our real differential here is SBT with aberrancy or VTAC, and within that SBT with aberrancy, you could say a flutter. Could this be a flutter? So all of those are still possible here. So if we're talking about what's going to change your treatment, the treatment's not based on the interpretation of the 12 lead, like the specific rhythm or dysrhythmia. The treatment's based on whether it's wide, narrow, stable, unstable, regular, irregular. Those are very easy to determine here. So we have a regular wide complex tachycardia. Now, is this patient stable or unstable? Based on the AHA criteria, based on this criteria that AHA gives, I would say this patient's unstable. Even if you don't think they're hypotense, you could, and they don't have altered mental status, they do have signs of shock, right? The pale, clammy skin, the syncope. This is an unstable patient based on the AHA criteria. So this patient should be cardioverted, but you have time. They're compos mentis, they're talking to you. You have time to probably get an IV, probably to give the sedation appropriately prior to cardioversion. There are times where you won't have that much time to get this patient cardioverted, but this presentation, I would say, you do have that time, and the provider did provide that sedation prior to cardioversion, and they did successfully cardiovert. Next question is, what setting do you want to cardiovert at? Because we don't really prescribe that anymore in the AHA algorithm, but the old train of thought was if it was regular and wide, 100 joules, right? 100 joules was the starting dose for that patient, and that is still accurate today. That would still be fine. So this patient could be cardioverted. They were and successfully cardioverted. And this was the subsequent rhythm. This 12 lead EKG has an extreme right axis. What does that mean? You have a negative QRS complex in lead 1, 2, and 3, which you generally only see with ventricular-oriented rhythms or hyperkalemia. But your ventricular rhythms often cause right axis deviation. Sure, there could be a congenital abnormality like dextrocardia or something like that, but for the most part, that means it's a ventricular origin. So you have a extreme right axis deviation, this wide QRS complex still. However, the morphology has changed. Now we have negative concordance or negative QRS complexes in V1 through V6, where before they were positive, right? So everything has changed. But remember the history. What does this patient have? If we go back to their history, it'll tell you what you're looking at. A pacemaker. They don't have a defibrillator, but they have a pacemaker. And it was quite easy for the provider to know that this was a paced rhythm because on the monitor itself, this was pretty much the same exact time as that 12 lead. It still shows you the pacer spikes. So on the 12 lead, the pacer spikes may have been removed by the monitor itself to allow for easier interpretation, but it's still quite clear on the monitor and on the subsequent hospital 12 lead, there are pacer spikes visible. This is the 12 lead from the hospital. And if you look at these little arrows across the top, those are indicating a paced rhythm, ventricular paced rhythm with AFib underlying. A lot of people don't realize if you have a paced rhythm, you could still have an atrial rhythm, right? So you could still have atrial fibrillation or atrial flutter or a sinus rhythm with a paced rhythm. It's very similar to a third degree AV block. And we're actually going to talk a little bit more about that here in a second. So this was the hospital 12 lead. The interesting thing here is the QRS axis is entirely different on this 12 lead. The only explanation I could have for that, I don't think that the internal pacemaker lead was changed. The other explanation was that the limb leads were misplaced either at the hospital or in the pre-hospital monitor, and that's why we have a different axis. So there's some things. If you're thinking is VTAC versus SVT with aberrancy, there's some things that can clue you into one or the other. For instance, a tall left ravitier. So when you have that right bundle branch block morphology in V1, if you ever see a taller left ravitier, right, it's spiked up top, and then down here you have a little bit of a notch indicating that this is a right bundle pattern, but it shouldn't be tall on the left side. So if it's bigger on the left side, then it's definitely VTAC. That's almost 100% specific for ventricular tachycardia with a right bundle branch block pattern. All right. Some other factors: if the age is greater than 35, if they have structural heart disease, ischemic heart disease, previous MI, CHF, cardiomyopathy, all of those things indicate more of a likelihood of ventricular tachycardia. So looking back at our 12 lead again, we don't have a taller left ravitier, so we can't use that criteria. All right. Josephson's sign. This is another indicator of VTAC, and that would be notching near the nadir of the S wave. The nadir just means the bottom of the S wave. So like the opposite of the peak of the R wave would be the nadir of the S wave. So if you were to call this the nadir of the S wave, then this would be the notching on the way down. I think this image is misleading, but if you have notching on the downstroke of the S wave, that's indicative of a ventricular tachycardia or ventricular origin for the wide complex tach. All right. So instead of using all of these different indicators independently, the Brugada brothers published a paper quite a while ago, I think it was 90, in Circulation, and they came up with something called the Brugada criteria. And this is really what is used by providers to determine or to differentiate VTAC or SVT with aberrancy. With that said, we already talked about the treatment. The treatment's the same either way. This is more of an academic discussion. It's nice to know that it's VTAC or SVT with aberrancy. When in doubt, assume it's VTAC. All right, so you go down this, and the first thing you look for is the absence of an RS complex. What that means is, like the QRS complex that we know and love, it has different names based on the waves within that complex. So if it has a positive and a negative wave, that's an RS, if it has a positive and a negative. So what this is saying is if it doesn't have both, if it doesn't have a positive and a negative wave, then it's likely VTAC, because over here to the right, so yes, we have the absence of RS complex in all precordial leads, we would say, okay, it's VTAC with a sensitivity of 21% and a specificity of 100%. So what the Brugada brothers did is they looked at research of over 200 cases, and they came up with criteria based on that research, and then looked at 554 wide complex tachycardia cases, put this criteria into place, and saw how specific and how sensitive it was based on the diagnosis of the 12 lead. So the sensitivity of 21% means that most VTACs won't actually have this finding, but if this finding exists, it definitely is ventricular tachycardia, 100%, right? So if there's no change, if they have completely positive QRS complexes or completely negative QRS complexes, which we call precordial concordance. So this is an example of precordial concordance, where every QRS complex is positive, right? And there's no RS, there's no S wave in any of these complexes. So this would be definitely VTAC according to their criteria, right? Looking back at our 12 lead, you could make the argument, because when I first looked at it, I thought it had positive precordial concordance, meaning every QRS complex in V1 through V6 was monophasic and upright. But if you were to follow the line down from what is clearly the J point in V1, then you could say that V2 has a little bit of an S wave. Now, bringing back the Josephson sign thing, any notching of that S wave right by the nadir, like you see here, is highly indicative of VTAC. So this would be highly indicative of VTAC. But let's not stop there. Let's go on. Let's say we didn't have the lack of an RS complex, right? So then you would go down to the next criteria, and you would look at your R to S interval. All right, R to S interval. What is that? That's the beginning of the QRS to that nadir of the S wave we talked about. That's your RS interval. So the beginning of the QRS to the nadir of the S wave. If that is 100 milliseconds or greater, you have a 98% chance that it's VTAC, but only 66% of VTACs actually present with this finding. All right, so 98% chance is pretty good. Let's look. All right, so I've enlarged our right precordial leads, which are V1 through V3, because that's where I think it's easiest to see. And that's the only place where we notice an S wave in the precordial leads. If you were to measure but from the beginning of the QRS complex, which I know in V1, it looks like it's over here, but if you find it in V2, which is the lead that's most in question here, it's really about right here. All right, so the beginning of the QRS complex to the nadir of the S wave is right there, and that's clearly over or longer than 100 milliseconds. We're almost at 200 milliseconds. 100 milliseconds would be 2.5 small boxes, which is halfway through this large box. So this large box is a 200 millisecond box. Halfway through is 100. So if you look here, this line is actually on the beginning of a box, and we're almost to the end of it, right? So we're clearly longer than 100 milliseconds, indicating that this is 98% chance that this is VTAC. But let's say we didn't see that. What would be the next thing? AV dissociation. And we already talked about AV dissociation a second ago, as it exists with paced rhythms. But with VTAC, many folks don't realize that ventricular tachycardia has a lot in common with a complete heart block. There is a complete AV disassociation. So the ventricles have a reentry tachycardia that are occurring, but that doesn't necessarily stop the atria from depolarizing on its own. So this is an example where there are P waves underlying, P waves that are occurring, and every once in a while you might have an indication that there's AV dissociation, such as a capture beat. So if you see a narrow complex with a P wave before it in the middle of what looks like VTAC, this is like confirming that it definitely is VTAC, 98% chance. If you see what's called a fusion beat, where you still have the P wave, and it looks almost like if you took this QRS and combined it with this QRS, the capture beat and the reentry tachycardia beat, you get what's called a fusion beat. That's another indication of AV dissociation. It's very difficult to see P waves within VTAC because it's usually so fast. No, the AV dissociation we know about is a complete heart block, right? A third degree AV block. It's not something familiar for most of us to think about in the setting of ventricular tachycardia, but your atrial rhythm can be separate from your ventricular rhythm here, and even with a complete heart block. Complete heart block is an interpretation we give to make it easy, but this is really a sinus bradycardia with an idioventricular escape rhythm, right? There's two different rhythms happening here because the atria and the ventricles are not talking to each other. So back to our 12 lead, there's no indication of AV dissociation that I can see. It would be very difficult to identify P waves. These QRSs are quite large, and there's no like regular abnormality that you'd be able to march out as a P wave. There's no capture beats, no fusion beats. So it's a little too difficult to identify AV dissociation. And then the next thing you would look for is a morphology criteria for VTAC present. This is the most difficult to remember. And both precordial leads V1, V2, and V6. So you would have to know this criteria. And this criteria for a left bundle branch block pattern versus a right bundle branch block pattern is different. So for a left bundle, which is not what we're looking at, but for a left bundle branch block pattern, this is what you would look for. The R wave is greater than 30 milliseconds in length. You have notching, that Josephson sign of the S wave, or C in this, which is that RS ratio is greater than 70 milliseconds. That would be in V1 or V2, and then you'd have to look at V6. For a right bundle branch block pattern, that's what we care about because that's what we're looking at right here. In V1, V2, it would be a monophasic R wave or a QR or RS. So you have a monophasic R wave in V1, and you have what could be argued as an RS in V2. So that would be inclusive. And then you'd have to also have that V6 criteria, which we do not have. The V6 criteria is an RS wave or almost an entirely Q wave or QS wave in V6. But if you look back at our 12 lead, V6 doesn't have a QS or an RS. There's just a monophasic R wave. So we do not have that criteria. So if you made it all the way through this algorithm and you didn't have any of these criteria mentioned, it has a sensitivity of almost 97% and a specificity of almost 99% for SVT with aberrancy. So it is pretty good to know, but in the clinical setting to provide treatment, it's not realistic. So we like talking about these things in the academic setting and knowing these independently. If you know AV dissociation is indicative of VTAC, it's easier to identify. So we typically rule in VTAC, not rule it out, because there's a lot more risk treating ventricular tachycardia with supraventricular treatments like cardizem. If you thought this was a flutter and you were treating it with cardizem and it wasn't a flutter, it was ventricular tachycardia, you can cause much more harm than good, especially if it was like an accessory pathway like WPW, that can be even worse. So a flutter, is there an argument for this to be a flutter? Now I will say, based on the Brugada criteria, we already concluded this was VTAC just because of the RS ratio alone. But why would somebody believe that this could be a flutter with aberrancy? That's reasonable, right? And if you were to think of it like this, draw out where these flutter waves would exist, then you can absolutely see how somebody would believe that this is atrial flutter, like with masked flutter waves within that QRS. So that's completely possible with wide complex tachycardias. All right, so let's talk about a little bit of the mechanism of a ventricular reentry. This is a little bit more of a complicated idea, but if you were to look at the ventricular conduction pathways in this format, so right here, coming down, that would be your His bundle, all right? And that bifurcates. The His bundle is now called the AV bundle. So basically between your SA node and your bundle branches, that's what that is. It bifurcates into the right bundle branch and the left bundle branch. The left bundle branch has two fascicles, but we're just going to talk about it as one conduction pathway, right? If you have a conduction block, such as a right bundle branch block, and that if you're looking at a VTAC that has a right bundle pattern, this is how the reentry that likely exists. So you have a right bundle branch block. What happens typically is conduction comes down the His bundle. It does not occur down the right bundle branch because that's blocked. It goes down the left bundle branch, then comes back over, and then it conducts from cell to cell to cell to cell over on the right side, causing a much slower conduction and a widening of the QRS. That's the aberrancy. That's where that comes from, right? Then we have what's called a reentry. What can happen when you have conduction delays on the right bundle side or on the left bundle side? It could happen either way, but we're talking about a right bundle branch block morphology. So what can happen here is conduction happens. Now follow the lighter color here. Conduction happens, like we said before, it gets blocked here, so it goes down the left bundle, comes across. Now by the time it makes it over to the right bundle, it's possible, right, that it can conduct through here slowly. Now follow the dark line, conduct through here slowly, cell to cell, and now these cells here have been repolarized. But since they've been repolarized, they want to depolarize from the conduction that's being brought forth. So when they depolarize, conduction then flows upwards up the His bundle, depolarizing cells that way, then back down the left bundle, and then this can continue in what we call a reentry circuit. It's very similar to an AV nodal reentry in that regard, that it takes advantage of repolarized cells. So that's the reentry circuit. If you want, you can consider Zine, and you likely should, depending on the patient presentation and what you know about that criteria. If it's highly likely that it's VTAC based on that Brugada criteria, then don't go with giving adenosine. If it's likely that it's SVT, then give that empiric adenosine and try to treat the patient that way. You know, cardioversion is a relatively safe treatment. We hold off for the unstable patient because it's quick, but it's painful. I think the pain part is the trepidation issue, but it is actually safer than the medications we administer for dysrhythmias. The patient needs to be converted, they need to be converted. So looking back at our 12 week that we started with, it's a wide complex tachycardia. If we're talking about treatment, we go down, wide complex tachycardia, stable, unstable, we treat based on those findings. But if we want to have that academic argument and try to interpret this further and know what this rhythm is, because I think this looks a lot like precordial concordance, but again, if we're making the argument that this is an S wave, we could still say it's likely VTAC. It's got a notching near the nadir of the S wave, and it has a very long RS ratio. That long RS ratio is a pretty big giveaway, all right? Sometimes you'll hear the word intrinsicoid deflection in reference to an interval within the QRS. That's talking about to the peak of the airway. So that's different from the RS ratio. So what happened for this patient? Well, they got cath and they found some stenosis, but it was less than 50% occlusion. This isn't somebody that gets stented. So you could say that was not the reason for the arrhythmia. They weren't having an MI. They did get an ICD. So they had a pacemaker, and now they probably got what is a more modern pacemaker that has an AICD as well. So now they have that cardioversion readily available, and they were prescribed amiodarone to be taken orally once a day. So they clearly thought it was ventricular in origin as well, but they didn't ever witness the wide complex tachycardia. They are, in the most part, going by our EKG and our treatments. And we did this patient a lot of favors, so we did a really good job. So it was a good case to review. I hope you guys all got something out of it.